This is the left eye. Again, a shield ulcer with limbal stem cell deficiency. So, what we did, we took the help of dermatologist in this, and the dermatologist, because he's been suffering from atopic dermatitis, so he was given azathioprine 20, the low dose azathioprine was given, and we just started with topical steroid, who initially and subsequently tapered it, and we found that he showed a remarkable improvement. And now today, he always, wishes me whenever there is some festival. He always is very, very good patience in terms of explorability and in terms of his administration of the medicines. This is the state of affair in his left eye, and at least he is able to do his own work without any taking help from anyone else. So the works of challenge doesn't stop here; it lies even in the treatment, and I'm sure my next speakers are going to, include the mimickers and other aspects they will clear with subsequent slides. And this baffleness is there because there is no set pattern of treatment strategy, and there are multiple anti-allergens lies in the market, and we are always confused what to be done in those cases. Thank you. Yeah, this is very true, because it's not only, though classic teaching is that the onset is around puberty, but it has been seen, and another classic is that it is wane off with passage of time as you process the adolescent. But we have seen patients who still have VKC with the pathognomic feature at 45 years of age also. So such patients we have to treat with the multiple allergens which are there in most of the practitioners, and I think so we should have to take that. Thank you.
Thank you. Any questions from the audience? Alright, so with that nice overview about different kinds of ocular allergies and different subtypes that we have, I'll move on to mimickers of ocular allergy. Because as we know, allergic conjunctivitis can be often overdiagnosed because there are a variety of conditions that can present to us with congestion, chemosis and watering. So here one victim to remember is that predominant symptom of ocular allergy is itching. Usually if there is no itching, it's unlikely to be a case of ocular allergy. So if we have to divide mimickers of ocular allergy into different subgroups, we have the conjunctivitis group, which could be more commonly viral or bacterial. It could also be toxic conjunctivitis, and especially because we are talking about young children, it could be a case of flictennular conjunctivitis. Then we have the dry eye subgroup of disorders, which would include phlebitis, blepharitis, which would cause evaporative dry eye, as well as cases of aqueous deficiency dry eye. And the other differential diagnosis could be episcleritis or ocular cicatricial pemphigoid, which is a differential diagnosis for atopic keratoconjunctivitis, as both can have significant amount of fibrosis and scarring. So let's talk about viral conjunctivitis. So this is what a typical patient of viral conjunctivitis would look like. A predominant symptom here would be more mainly more than itching, and an important sign would be that they would have stickiness of the eyes in the morning if we specifically ask that question, and there might be associated lid edema. And unlike allergic conjunctivitis, which involves usually both the eyes simultaneously, viral conjunctivitis first involves one eye and then spreads to the other. If we examine the lower fornix, there might be serous discharge in the lower fornix along with follicular reaction much more than the papillary reaction, which is typically seen in cases of allergic conjunctivitis. Now, usually viral conjunctivitis does not present with blurriness of vision or any visual symptoms, but there can be these subepithelial infiltrates, which is an antigen-antibody reaction, which could cause glare or blurred vision in these patients as well. If we are confused about what differential it is, whether it is SPKs or whether it is case of allergy causing these reactions, we could also palpate for preauricular lymph node involvement, and these patients might have associated viral upper respiratory tract infection as well as fever. Now, bacterial conjunctivitis we are less likely to confuse with ocular allergies because usually they would have a significant amount of purulent discharge and there might be presence of membranes as well, and the patients will complain of intense stickiness of the lids in the morning. Another important differentiator to remember is cases of toxic conjunctivitis, so we always have to ask for the history of usage of any eye drops, because especially anti-glaucoma medications or preservatives that the patient is using, or if he is using any off-label drops, plant extracts, all of them can lead to toxicity to the ocular surface. Now here the congestion and all the signs and symptoms are more in the lower tarsal conjunctiva, unlike allergy where there is more involvement of upper tarsal conjunctiva. And they could have associated inferior SPKs and corneal edema. Now if we have a young patient who presents to us with a picture like this, this could be a case of lectennular keratoconjunctivitis. Now to differentiate, like this is a young 8-year-old boy who presented with a picture like this. These cases are usually unilateral and unlikely to be bilateral, again unlike ocular allergy. And another important way to differentiate them is to stain, and usually if there is a case of ictal, it will be an appearance of an ulcerated nodule, whereas limbal papillae won't have this kind of a staining. They might take a diffuse staining if their patient has limbal papillae. So this is one way to differentiate between these two. Now let's talk about mebovitis and blepharitis, which are very commonly misdiagnosed as allergic conjunctivitis. These patients usually have more of irritation and burning sensation, or they might either complain of watering rather than itching. So it is extremely important to look at the eyelashes, look for deposits on the base of the eyelashes, and look at the meibomian glands before we label a case with ocular allergy. Sometimes we might have patients like this who actually have marginal keratitis, and this can be very confusing and might look like a limbal papillae to us. So here, even the position of where we get these infiltrates could be where the lid margin touches the cornea, and again associated signs and symptoms like these patients can have inferior SPKs, or looking at infrared topography will help us in differentiating these two conditions. And again, marginal keratitis is more likely to be unilateral, although there can be bilateral presentations as well. As we know, meibomitis and blepharitis again are disorders which are bilateral in nature. Now, very rarely we can have cases like this. This is a case of a 4-year-old boy who was being treated as allergic conjunctivitis for a long time. There's been a lot of talk about Demodex in the last couple of years, but we also have to remember that pediculosis can also lead to blepharitis, and this is another cause wherein the patient would have similar symptoms to allergic conjunctivitis. So this patient actually had pediculosis, and we removed all of these lice on the eyelashes, and that's how he got relieved of his symptoms. Now, aqueous deficiency dry eye can also look or get confused with ocular allergies, because long-standing ocular allergies in turn can cause dryness in the eye. Now, these patients are usually in older age group, and they can present to us again with symptoms of drippiness and dryness and associated intermittent blurring of vision, because they will have these kind of superficial punctate keratitis. Now, we must ask for a history of underlying autoimmune disease when we say a case like this, and that would again point us to the right diagnosis. Again, the presentation in terms of the distribution of SPKs would give us a clue. They would be more seriously. So not just to examine the lids, but to also look at the tone of the tarsus is important when we are evaluating these cases. Although these patients are rare, but it's something that we need to keep in mind. Then we have the episcleritis, which does not cause any itching or any significant pain or discharge. It presents as a painless congestion, and there will be no papillary reaction or no follicles. Ocular cicatricial pemphigoid can be confused with AKC. The question that we need to ask is that it will not be associated with atopic dermatitis, although there can be skin involvement in patients with OCT, and these patients usually have severe dry eye. It is a progressive bilateral disease in most patients, and when we examine, we will see signs of scarring, fornication, foreshortening, symplepharon, as well as ocular surface cicatrization. So to narrow down the differential diagnosis, we first, according to the symptoms. So if the patient primarily complains of itching, we are probably looking at a case of ocular allergy. If the predominant symptom is burning and ocular irritation, we are probably looking at dry eyes. And the main symptom, if it's discharge or stickiness of lids in the morning, it could be a case of viral conjunctivitis. So to put it all in a nutshell, if there is no itching and redness, we should consider alternate diagnosis. Look at the lid margins and see whether the patient is suffering from uveitis or blepharitis. Another question to ask is whether the patient has skin manifestations. It could be a case of AKC, or sometimes even patients with perennial allergic conjunctivitis can have associated skin manifestations. Does the patient have rhinitis, asthma? That would again strengthen our diagnosis of ocular allergy. A GPC could be another differential diagnosis for ocular allergy, so asking for contact lens usage is also important. And patients with severe seasonal itching, with Robi discharge, with cobblestone appearance, with this diffuse pigmentation that Dr. AIOC2024 demonstrated very beautifully, are patients of VKC. And last but not least, it could be a case of irritative conjunctivitis, especially people who come from polluted areas. Thank you for your patience.
In fact, I'm glad you brought up the topic of Allergic blepharitis that we have also seen, especially the place that I'm practicing now, Enigma, in more of a tertiary care center. And now we've started the new place in Mumbai, where we get a lot of patients who come and we just walk in. So more of the first attention that they're seeking, or the second doctor that they're seeking. So it seems that Allergic blepharitis is vastly underdiagnosed. And before we label as allergic, so for allergy and allergy, itching either. So in the Allergic classically, they don't have continuous itching either. So you see that pediatric patient, so examine the lids and lashes very closely. And even the same that you said of pediculosis, because of the lower associated point that I'm dealing with, even the slum population and so on. So this also has, I've noticed that it's a little bit on the upswing. So these common problems we should look at first, because it's not, you can get a one-time solution for these problems as opposed to allergy, which can keep happening year on year. So thanks for bringing all of these points up.
Thank you, ma'am. Thank you so much.
Or questions from the audience here. So I'm very happy that we have a small group in the audience, but obviously they're a very motivated group to be attending this session. So it's kind of like a one-on-one discussion, and anybody is free to ask any questions that they might have here.
I think the most common mimicker, like Dr. Somshila was rightly pointing out, is uveitis and blepharitis. Patients who have evaporative dry eye related to lid margin disease, those I feel are very commonly misdiagnosed as ocular allergy, because it tends to become the default diagnosis for a patient who has diffuse redness, irritation. Like we can't highlight enough the importance of examining the lid margin, as well as looking at the eyelashes, looking at the hygiene of the lid margin. So those become very, very important before we label a patient as allergic conjunctivitis. So thank you so much. I would like to invite Dr. Somshila for her talk on complications of ocular allergy, as well as the role of surgery in ocular allergy. I think we will talk about the medical management towards the end.
And very good morning to everyone. As I said, it's a real pleasure to see very committed people sitting in this hall for this session. So, though I've been given 2 topics, I'll try my best to make it less boring, and I'll try to cover it up and wrap it up a little faster, because if anybody's going on talking for 20 minutes, it's very good. So, though we should have ideally gone with medical management, but I guess Dr. Namrata is in some other session and she will cover the medical management, but I'm finishing up the surgical management. So luckily for us, BKC is not really a surgical disease. So most of the time we need both a modification of the environment for the patient and also modify the behavior of eye rubbing if we can, and use of medication. So surgery itself is not very frequent, but yes, there are some indications and then some procedures which will be what we already know, or some procedures which will be new to some of us. So as I was saying that I am from Enigma Eye Institute in Hyderabad. I've been practicing there for many years. But recently, for the past 1 year, I shifted to Mumbai city to build a new institute over there, so which is going to be similar to Enigma. So I've seen a lot of change in the kind of patients that come. In Enigma Eye Institute, we get a lot of tertiary care. So all the very severe allergies that you see, that you read in the that we have published, so those kind of allergies come to tertiary care. But what I'm seeing now in Mumbai is because we're located in a place which is very populated. So we have patients just walking in with primary disease. So it's a unique opportunity for me now, after so many years, to see the primary disease, how to present to the first level ophthalmologist for the point of care. So now practice is, for me, it's getting simpler in that way. So it cannot be overemphasized that various allergic eye diseases and the conditions that are associated, for example, keratoconus. So these have certain sequelae and they have complications that can cause severe damage. This is a patient with BKC, has this limbal area involved. So if this goes on into adulthood also sometimes, as Ikeda pointed out, and then these patients can have stem cell deficiency here. The ocular surface gets unstable. This is a patient with atopic keratoconjunctivitis, and you can see what a dense corneal scar this young patient has. So obviously we need to do some kind of surgical therapy, not to fix the allergy, but to deal with the complication or the sequelae. So I'm going to list out what are the various indications where we sometimes resort to surgery. So sometimes these indications are part of the disease process itself. For example, very bad and severe giant papillary conjunctivitis, I will go through that. Shield ulcer, as was mentioned earlier, that's another common indication where we sometimes resort to surgery. Coming to the complications we can have due to the eye disease, these include due to the medication. So steroid-related cataract and steroid-induced glaucoma. These are 2 medication-related problems, and these 2 also require sometimes surgical therapy. Certainly cataract requires surgery. Then limbal stem cell deficiency is a complication not of the medication, but due to chronic disease, very long-standing disease. So for example, this is a patient that, one of my patients from Hyderabad, now I'm saying in Mumbai, comes with such an exuberant limbal proliferation. You can see those Strantas dots and what Alok was saying, this pigmentation over here. So these are all classic signs. We had a doubt, what am I looking at? But when you see all of the other signs, put together the history of chronic eye rubbing for many years, then you know that we're looking at BKC itself. Sometimes it looks very bizarre. So these patients, as we take control of the disease, but the bystander tissue, that is the limbal stem cells, will undergo damage, and the patient can have a stem cell deficiency which needs some kind of therapy. And of course, complications like microbial keratitis, especially you've seen when you have a shield ulcer, can get infected, and corneal scarring, as I mentioned earlier. So here's a patient now, the limbal part of it, disease is now quiet, so you see all of this 360 scarring literally. The pseudogerontoxin has almost migrated centrally, and this patient also has keratoconus. So it's quite a complex and challenging case. So coming to the first indication, giant papillary conjunctivitis, it's not really a surgical therapy, but one simple therapy that works very well, especially in pediatric patients with supraclassical steroid injection. So what we do is use either methylprednisolone from the injection, but that makes it expensive for the patient, or you can use triamcinolone acetonide, which is the same thing, Pinocort or Orocort that we have. And these are patients with very severe giant papillary, cobblestone kind of papillary in pediatric patients, continuously rubbing their eyes. So this is like giving, a pulse dose of the steroid. You have very dramatic results. And day of itself, the child is so much better. Of course, you need to monitor and drop your pressure. And in my experience, you can repeat it after 3 months or 6 months, but not too frequently. Eventually, these patients will do well after 1 or 2 doses of this injection. But maybe it's on a timer. Just wanted to show a video here. So, how to do this?
Hello.
Alright. So how to do this is to take the 27 gauge is better, 26 gauge also you can load the injection on it. Usually it's a very tight space. Here there's a lot of loose conjunctiva to get a lot of drug through. If it's a young child, I usually inject 0.5. Older child, a very loose conjunctiva, you can even technically go up to 0.1, but 0.5 most of the time is enough. With that you would get almost 20 milligram of the drug. And that's it. So you can even do this under very good topical anesthesia. For an adult patient, you can select topical anesthesia. Maybe for a pediatric patient, a very short anesthesia is required to administer this drug. It doesn't bleed too much, and you see the results, as I said, by the next week. Just raise the wheel in the supratarsal space, and it's a simple technique. So the second indication was what you do for the giant papillae itself. I said that you can give a steroid injection for taking care of the disease, but sometimes you have this very huge giant papillae. We know traditionally that you should not just shave, excise it. You're going to cause a lot of scarring and you won't solve the problem. But certain patients, these papillae keep on persisting in adulthood. They keep rubbing the cornea and then they can cause corneal surface problems and perpetuate the cycle for the patient. So various publications are there which talk about simple excision or cryoablation, but this first technique, number one, has almost a 50-60% chance of reactivation or recurrence. So it's not a very great technique. Other authors have used supratarsal injection and with cyclosporin A also, and they have reported moderate success in kind of getting rid of the papillae. Some studies have published the use of mitomycin C. I would sort of not recommend it because we know that mitomycin C has other problems in long term. The techniques that we can do more safely is when you have these very huge papillae, when you excise them, you can either put a conjunctival autograft or amniotic membrane transplant. Because they have a lot of experience with harvesting oral mucous membrane and placing it there with very good results. What we do is at our center is that we use amniotic membrane. So for a few patients who have this very severe papillae, excise the papillae and put an amniotic membrane in that place. So one example I can point out is this patient who has VKC, is now 16 years old but has VKC since age 12, and look at these giant papillae. So every time the young adult almost has all the time severe allergy, chronic eye rubbing, and recurrent shield ulcers like in this picture here, and a very poor ocular surface because these papillae are both mechanically rubbing it and they have a lot of chemokines, chemical agents which perpetuate the allergy. And the child is also depressed because not doing well at school. So we decided to go ahead and surgically excise. It's not difficult to excise, just use instrument to nicely excise the papillae without causing too much bleeding. And after excision, placed an amniotic membrane on that with supratarsal steroid injection. Also, we need to treat the patient with topical steroids, both control it preoperatively as well as postoperatively. For this patient, we also give a short term of low dose of oral steroids, and our go-to therapy is usually tacrolimus eye ointment for long term. So the patient is doing well, and he still continues to have mild reactivation because we have not fixed the disease per se. But the good thing is now it's 5 years of follow-up. He's completed his engineering studies and now he recently got a job. Sometimes, like Alok was mentioning, that these patients are so grateful that they get back to you. So this patient also is in touch with me and is very happy that the patient he's got a job now.
Coming to shield ulcer, this is a very peculiar condition to AKC and VKC. And it has 4 grades, if you remember. So grade 1 simply needs topical steroids. Grade 1 has nearly a clear base. It's called shield ulcer because of the shape, like a shield-like shape, triangular shape or something like that, and usually located in the optic membrane to sort of compensate for the stromal loss that you have over here. And we've had good results in these advanced shield ulcers where we have placed amniotic membrane. One more problem that can happen with shield ulcers is secondary infection. So we had an 8-year-old girl who presented with bilateral palpable VKC, and in her right eye she had this shield ulcer which had a lot of infiltrates. You saw that there were more than one foci of infiltrate, and we scraped it. She also had giant papillary conjunctivitis. The papillae there was very, very clear that it is VKC only, and she developed, it was an infection. Luckily for us, she improved rapidly to topical antibiotics. So we published our results where we saw that it's not necessary to use amniotic membrane for all the shield ulcers, but when you have grade 3 ulcers, using the amniotic membrane helps rapid re-epithelialization of this case. We also looked at what are all the complications that can happen in VKC, and we studied close to 500 patients of VKC, and what we saw that the commonest complications we had in them which can affect vision includes corneal scar because you proceed with any surgical therapy. Here is a 6-year-old child who had bilateral advanced keratoconus, and the child presented with what in one eye was resolving eye drops, sorry for the poor pictures quality for the age, and in the other eye the child had active eye drops. So what we did is that, it's a 10-year-old, what we did is that we went ahead to do, in those days I would do desmetopexy, that was my first choice. So after the first desmetopexy, by day 4, we see that there's really no clearing. This is pre-op and this is post-op, there's still a lot of fluid. So we did a repeat desmetopexy for this patient. This was a repeat desmetopexy where not only, you can see how severely edematous the cornea is, and the cornea is extremely thin also. So in the repeat desmetopexy, what we did is made a paracentesis, and first of all let all the fluid from the AC come out. Second is I made a venting incision like how we do in DSEC, and from that also squeezed out the fluid present in the stromal areas. If you remember the OCT, there are a lot of pockets of fluid. So remembering the OCT, we don't have an intra-op OCT, but squeezed out the fluid in the intervening area in the stroma, literally massaging it out gently. You can see that suddenly some fluid gushes out. So the idea is to get the stroma as compact as we could. So once we sort of manually expressed the fluid that was there in the stroma, then we went in with a full air fill. We didn't use gas. We thought that now that we've removed all the fluid, the air fill might work. And these were the days before I was not really doing compression sutures. Of course, now if I have a case like this, I would definitely apply compression sutures as well. And finally, luckily for us, we got a good result. The child eventually has grown up to late teens, I think, or early teens at this stage. And the vision with contact lens is 20/50. So we're not yet done a transplant. Always remember to do a peripheral iridectomy when you leave in that much of air in the anterior chamber. So this was the end of the surgery for this patient. And 6 months later, you can see that there's a diffuse scarring. So with the scleral contact lens, the child sees well and is managing a school now, and maybe we may do a transplant, but when the child grows up. So the role of compression sutures, I mentioned 2-3 times, is that it is a huge help in rapid resolution of, especially in large eye drops. So thanks to my colleague Dr. Sunita Chaurasia, I think we have modified at least at LVPI our practice so that whenever we get patients with acute eye drops, more than the desmetopexy part of it, we focus on how to take the sutures. The idea is to spread out the sutures over the cornea so that we bring the posterior layer close to the anterior layer. And yeah, we might put in some air also, but primarily it's the sutures that are causing the decompression. And based on her in publications, both prospective study as well as our mixed experience, we have seen extremely good results with this technique. Finally, on limbal stem cell deficiency in VKC. So we mentioned that the chronic limbal inflammation can lead to LSCD. We recognize this. This is one of my very early publications when I joined LVPI. We recognize that chronic VKC, thanks to Dr. Sangwan and his observation, can cause LSCD. And we have to address this problem the same way as we do with LSCD. In those days, we used to do cultivated limbal epithelial cells, and in these days, we definitely do simple limbal epithelial transplant, SLET surgery basically, for once you've identified that VKC patients have chronic LSED. Only problem is that if you're doing SLET, because usually it's a bilateral condition, then you have to select a donor or cadaveric tissue in order to do SLET for a bilateral condition. So that is one sort of a disadvantage of having to do these procedures in these patients. So steroid-induced complication, you are very well aware that you can have glaucoma. It's always overemphasized not to overuse medical therapy in terms of steroids without any management of IOP. Unfortunately, in our country, steroids are given over the counter in pharmacies, and once the patient or the parents feel that the child get maximum relief with this medication, so they continue to use steroids for years together, and when they come to us, we see very severe glaucoma, including advanced disc damage and so on. So we had published that series. Luckily, I'm sure those of us who have been practicing for a long time, luckily the glaucoma part of it seems to have gone down. There's a lot of sensibility now, and many doctors are advising the patients not to use steroids. Patients are also more aware. So the glaucoma part of use of steroids has definitely gone down. And in cataract, the issues are, what if the measurement of the keratometry becomes very tricky because of the corneal scarring, and if you're not careful, so for example, this patient, when you first measure, the IOL part comes as 14 diopters, but when you use various techniques, it comes as -2 diopters. So that is how much variability you can have if you have a patient who has a cataract and corneal scar as well. So that's the reason why, although the outcomes of cataract surgery can be very good, it's cataract surgery, but measurement of the keratometry, accurate biometry can be a challenge in these patients. So I'll skip this case, and that's what I had. Thank you very much for listening.
Ma'am, I have a few points to ask. One, what's your experience of surgical excision of GPC as you highlighted? And second, when you, in desmetopexy that you have read it out, you pass the sutures across the desmet to AC and like that, how to do it? And third, what's your take on cataract in VKC?
For the question on Right. So for GPC, the surgical therapy is very in a very small subset. So most of the time you don't need to address it surgically at all. It will regress, and as the child grows up, there may be more of a pannus or some kind of regression you'll see. So no need to do it in too many cases. There's only a very small subset, especially older children or adult patients, where you attribute that the giant papillae are mainly perpetuating the cause of the inflammation. So very small subset of patients I resort to surgical therapy. As I mentioned, that what I would do is more like a very careful, sort of a gentle shave excision, and so a multi-layered AMG on the tarsal conjunctiva, and the Shankar Netralaya group has talked about the same thing, but they use mucous membrane. And my go-to would be using corticosteroids initially, and maybe even oral, some kind of anti-inflammatory agent, either steroids or immunomodulators, and topical tacrolimus eye ointment for a long time. Recurrence-wise, the disease does recur, but the severity goes down. So that's the reason for me to select this. Coming to the last question was on VKC and cataract. Okay, so desmetopexy and compression sutures. Intent is not to do full thickness. You don't have to do full thickness. The suture is not going to hold the desmet's membrane. What the suture does is, what the sutures do are to radially push back or flatten the cornea, so that the space, the gap, the physical gap between the desmase membrane and the anterior stroma gets reduced. The compression forces also act in such a way that it's hard for fluid to accumulate more and more into the corneal stroma. It acts as a barrier to fluid accumulation. So that is the theory. So it doesn't have to be full thickness at all. It can be a little deep, as deep as you can get, but these are very soft tissue. It's very hard to suture. And also because most of these cases are very advanced keratoconus, so you have to be very careful that you don't have a large perforation. You may have a mini micro perforation sometimes. So it's radially oriented, or sometimes even pentagonal, based on whether the DM break is horizontal or vertical. So you can decide based on that. And there is a certain, as was published, a certain way of deciding how should the sutures be placed. So it is, in my mind, it is something like how you mattress, how you use it for a corneal tear to bring it together. But we are not going to enter through the Descemet's membrane in any way. So that's how the compression suture, it's to compress the cornea. It's not to suture the break. Exactly, yes. Not only that, but also to prevent more fluid, because you flatten the cornea so much, there's no space for the fluid to anymore go into the stroma. So the only thing that can happen is the DM will get opposed to the cornea with an AC fluid, the IOP itself will get opposed, and the pseudo DM will form, because these are all young patients, and that will seal the area where there's a break.
Ma'am, and I just wanted to ask your opinion on this. If I experience the few cases that I've done with these compression sutures, some patients have immediate response, like
Right.
the visual acuity improvement is
Yes.
immediate for a few
Yeah.
of these cases. Even the next day post-op, they feel
Right.
significantly better. So what has your experience been in terms of immediate recovery because of the fluid has been relieved and the compression that
Yeah.
these sutures cause, as well as the long-term outcomes of this technique?
In the earlier patients where we would examine, where we were studying them, so I've seen that the edema gets clear in an hour's time. So you do this case and open the patch because you want to make sure that you don't have a pupillary block, and you see that the edema is already clearing. So it's probably so after that, of course, we stopped opening the patch and so on. We see them the next day. But within a few hours of the sutures, if you have placed them correctly, you have relief. And this continues. It doesn't recur. So we've had more success than I've had with desmetopexy. For the past so many years I was doing that, and sometimes you would have to do a repeat desmetopexy. And now for the past few years I've been doing this and I've never had to repeat it. The cataract and VKC, typically either you have a nice clean case where VKC, the patient has been using steroids, and so that's why you have the cataract. So there literally, except if the ocular surface has it's showing some instability, for example, you have a lot of SPKs, then your biometry becomes a problem. You can also have cataract in cases where there's corneal scarring, limbal stem cell deficiency, or keratoconus. There the biometry is quite tricky. In both cases, we have to control the allergy more because you don't want the patient to keep rubbing the eye post-operatively also. But I'm not trying to underplay it, but I think tackling cataract surgery in a straightforward VKC is fairly simple. You get extremely good results. Of course, you'll get PCOs in all of these patients. Don't go with premium lenses or multifocal lenses and so on in these patients. And often they may have some toricity, so you have to handle that also. Thank you very much.
Do we have any questions from the audience, Dr. Shukshila? Yes, please, sir. Do we have any questions? So we will take this question after Professor Namrata Sharma's talk. She will be talking about medical management and different drugs that we have available. So I think by the end of this talk, we can talk in total about the management of all the cases.
For making me a part of this important instruction course, and I welcome you all to the 82nd AIOC conference, which is being held at Kolkata. I'll be talking to you about medical management of allergic eye disease, the drugs available in our armamentarium, and there are no financial or proprietary interests. So we all know that the management of allergic eye disease could be pharmacological or could be non-pharmacological. And in the pharmacological treatment, you have anti-allergic drugs, anti-inflammatory drugs, lubricants, and systemic therapy. So anti-allergic drugs, as the name suggests, are most effective, which could be topical histamines, antihistamines, mast cell stabilizers, and dual-acting drugs. And topical antihistamines could be are generally histamine receptor antagonistic, which are given in QID doses, such as levocabastin and emedastin, and they cause transient burning sensation and dry sensation also. Mast cell stabilizers are used, such as sodium chromoglycate or nidochromal sodium, which inhibits the mast cell degranulation, again given in QID doses, and dual acting would have both. That means there would be antihistaminic as well as mast cell stabilizer, and so it's given in BD doses, and there is transient burning sensation. But examples are bepotestin, ketotifen, and olopatadine. So initially when the patient comes, I generally like to give lubricants, because the lubricants, they wash off some of the allergens. The second drug in mild cases, which possibly I'll give, is topical antihistamines. and because they block the inflammatory effect of the endogenous histamine, and drugs which can be given are levocabastin or amidestin in QID doses. Now, they are not going to treat the disease, but they are in some way going to decrease your symptoms. But this burning sensation and dry sensation will definitely be there. So if it is a mild disease, then you can try topical antihistamines, but be careful, all antihistaminics will cause some element of dryness or dry eye. So preferably avoid them in severely dry eyes. Then mast cell stabilizers could be your sodium chromoglycate, nidochromal sodium or lodoxamide, which inhibits the mast cell degranulation and prevents the release of cytokines. And lodoxamide also inhibits the eosinophil activation and degranulation, and nidochromal acts on multiple cells. Again, the frequency is QID, and it can be given on a long-term basis, although it is slow in its action. Prophylactic dosing can be given, and it is not enough to treat the disease. So once you know, especially when it is seasonal, that it is about to come, in those cases just prior to the season, when your allergic eye disease gets activated in the patient, this can be given, but it will again cause transient burning sensation. I think the most popular ones, or the most which are used nowadays, are the dual acting ones, which are both, which would have a histamine receptor blockade and will have a mast cell stabilizing property. And also they have some amount of anti-inflammatory property, because it will inhibit the release of various mediators and chemotaxins, etc., which will also decrease the vascular permeability. Now, the commonly available drugs are epinastin, ketotifen, olopatadine, alcaftadine, and azilastin, and the frequency is again twice a day. Now, they act very rapidly because they have an antihistaminic, and they will also give you long-term benefit because of the mast cell stabilization, and would have minimal adverse events. Then amongst the category of anti-inflammatory, you have topical NSAIDs, corticosteroids and immunomodulators. Topical NSAIDs I generally don't like to give, because these patients would often also have some ocular surface disease, and then if you give topical NSAIDs, then this gets aggravated, and these could be ketorolac or diclofenac. The frequency is generally 2 to 3 times a day, and like I said, most cases would like to avoid these drugs. Topical steroids you may have to give in the form of lotoprednol, FML, dexamethasone, betamethasone, prednisolone or difluprednate. So if it is a mild one, I would rather give a lotoprednal or a fluorometholone, because that is more surface friendly. If I have to use dexamethasone, betamethasone, prednisolone, I would do it for more severe cases. But for milder, moderate cases, one can use fluorometholone or lotoprednol. And generally it is preferable to use steroids with a low strength and low effect on intraocular pressure, especially when they are steroid responders with increase in the intraocular pressure, which include fluorometholone, even remoxilin. I don't know if this is available here, or even lotoprednol. The latter two are definitely available here. So as far as the steroids are concerned, there are two treatment regimes: the pulse to the prolonged treatment. In the pulse treatment, you give it TDS or QID for 3 to 5 days. In prolonged therapy, you give it 3 to 4 drops per day for 1 to 3 weeks, and then do a slow taper, especially in the chronic forms. And in very severe cases, especially in children, when you really have to break that cycle, that vicious cycle which is there, then in those cases you can also give a short course of systemic steroids, because that will break the vicious cycle. Supratarsal injections of steroids in regular or depot formulation, I'm sure Somshila must have talked about. And of course, one has to be careful, because there can be raise in intraocular pressure, glaucoma and cataracts in these cases. Immunomodulators play an important role as such also in allergic eye disease, and also when the requirement of the topical steroids they increase. So you can use either cyclosporin or tacrolimus. And cyclosporin is available in the concentration of 0.05%, 0.1%, even 0.9%. And there are various forms of it which are available, which include the nanomicellar one, and there are various other variants also which are there. And tacrolimus is available in the ointment formulation, varying in concentration from 0.03 to 0.1%. People very refractory cases have also used topical mitomycin. Now, topical vasoconstrictors can be given, but again, their action does not last for too long, and they may cause itching and redness, and more importantly, dryness. I think topical lubricant should always be given in allergic eye disease, whatever drug you are giving, whether you are giving dual-acting one or antihistaminic, or the one which is mast cell, causes mast cell degranulation. And like I said earlier, people have tried systemic steroids. Oral cyclosporin has also been tried. IV immunoglobulins have been. Then there are other biosimilars which have been tried for the same. Of course, the non-pharmacological treatment will give some amount of symptomatic relief in the form of cold compresses, saline and cold artificial tears or ointments. And one should avoid eye rubbing, and if it is very severe, then one can wear dark goggles. So, to conclude, in mild cases, like I said, in all cases, mild, moderate or severe, I would like to give lubricants. If it is a mild one, then only antihistamines. In moderate cases, dual acting one. In very severe cases, you may use immunomodulator, sometimes even topical steroids. And once you have to break the cycle, then systemic steroids can be used, especially in cases of children. Also, important thing is that prophylactically, when you know that it is seasonal and it is going to come year after year, then prophylactically the dual acting drugs can be given when the season starts. So thank you very much for your kind attention.
Ma'am, what's your experience of using 0.5% cyclosporin? Is it really effective in allergy, or what's your take on that? Normally we have read it's 1% or 2%.
So for allergic eye disease, like for other indications, you could increase your concentrations of cyclosporin. I feel for allergic eye disease, 0.05% is good enough. You really don't need to increase the concentration of cyclosporin. If I had a choice, if it was still not responding, I would increase the dose of steroids rather than the dose of cyclosporin. Any other question, any query, anybody wants to talk about? Both are similar. I somehow prefer, because I tend to give more fluoromethalon. So my go-to drug is fluoromethalon. I have no financial interest in any of the two. I don't think so. Both perhaps act similarly only. But like I said, if it is an inflammation which is inside the eye, and I'm sure Soapshila can pitch in for this, you would go in for, steroids like dexamethasone and betamethasone. But if it is on the surface-friendly topical steroids are fluoromethalon and loteprednol. Anybody would have experience between these two, fluoromethalon and lotepred?
No, I strongly believe that you can use either of the two drugs. There's some preparations, if you want to be very scientific, there's some preparations of fluoromethalone which have more propensity to raise the intraocular pressure. And loteprednol has a couple of 2-3 doses, strengths formulation which it's available. So those are the only reasons. So fluoromethalone is more of a solution and loteprednol is more of a suspension. So these are the reasons. I honestly not sure if it makes any difference between the two. You can select whichever you're familiar with.
So GPC, cyclosporin eye drops in general you can give for years together. It is not going to have any harmful effect, except that it may cause stinging, which happens in 17% of the cases. But otherwise it is not secreted in your blood, or it doesn't cause any systemic effects for sure, and will not cause effects even locally. People have given it ranging from 1 year to even 5 years. We have studies with 2 years. So 5-year follow-up is also there, and that too in children is also there, but they've not shown any side effects. So you can give it for a prolonged period of time. Only thing is sometimes it gets expensive, especially if you're using the expensive formulations. I try to use only one. I don't see the benefit of using both of them together.
Actually, for just a comment on this, for years we were using cyclosporin before we had tacrolimus, and now for years we're using tacrolimus and stopped using cyclosporin for allergy. So there are two ways to apply it. If I have a child or patient who has irritation, then we ask them to massage it on the lid skin. So it has been shown that there's very good penetration. Actually, the drug is so to speak, we're using it off-label for the eye. It's actually meant for skin, not for mucous membrane. So that's why they have the stinging. So the idea is that rub a generous amount on top of the lid skin. Not the margin, on the eyelid. So this is especially useful for patients with the GPC kind of VKC. So whenever I have a child, the parents say that it's stinging, so we just tell them start applying it on the eyelid, and it seems to work very well. This is after years of using cyclosporin, where I felt it really did not have any benefit. Maybe because we don't have the strength, 1 or 2% would probably work better, but that causes a lot of stinging, as you know, and now it's not really commercially available, so it's very hard to use that strength of cyclosporin. So VKC is a challenging disease for many reasons, as you mentioned. I'm sure Dr. Namita would also agree that one is the counseling. So VKC is the one kind of patient where we get the entire family in the room. How many ever people have come who take care of the patient in the room and spend a lot of time on counseling. And this, you need many times rounds of counseling for these patients. And I try my best to avoid using topical steroids if it's high dose steroid. So use a low dose steroid, and then I even use oral medications in order to avoid topical steroids. And eventually, for a short course, for a limited period of time, especially when they have that huge cycle of eye rubbing and it's very bad, and the kind of patients we get in RP center or in tertiary care centers for those patients. And once you break that cycle by whichever method, counseling, measures to control the eye disease like cold compresses or whatever we can explain to the patient, agents such as Montelukast, cetrizine or whatever else works. So once we break that cycle of eye rubbing, then you get the child out of the allergy, and then you can use tacrolimus. Using that in the starting will not work at all. It's unnecessary. So my practice now is very simple. Start off with steroids. I don't use lubricants, don't use mast cell stabilizers, nothing. When we get the severe patients, start off with topical steroids, typically low dose, see if that's working. If not, I push to full dose for a short while, prednisolone or something like that. Switch to oral if it's still not getting control. Once it's controlled, I add in tacrolimus. I've stopped using lubricants. I think they're just a waste of money. I'd rather have the patient spend on these drugs. There's nothing that lubricant does. What does it do? So, it doesn't do anything.
It is supposed to wash away the allergens. And if you look at, although because we don't have any studies with and without lubricants, maybe we should do. But if you see everywhere and all the reviews and everywhere, I feel lubricants.
Sure, I don't know.
Effect.
I could not either, yeah. So I'm telling you something that is like, so I'm telling you not use lubricants, I'm surprised that we have resistance.
It works in Somshila's hands, so that's perfectly okay.
No, so just to propagate this discussion, the lubricants will wash out the allergens for a very short while. I mean, I have no problem using lubricants, but I know that is not my solution for the allergy. So the mildest of disease, I also use lubricants, and then my counseling and cold compresses, all of that. Cetrizine, Montelukast, treat the running nose, treat the systemic problem, whatever it may be, and get the child out of the bad hygiene or things like that, bad habit. And yes, lubricants, but anything beyond. So my therapy is one drug at a time, and so that the most effective first, then followed by the next and the next.
For making me a part of this important instruction course, and I welcome you all to the 82nd AIOC conference, which is being held at Kolkata. I will be talking to you about medical management of allergic eye disease, the drugs available in our armamentarium, and there are no financial or proprietary interests. So we all know that the management of allergic eye disease could be pharmacological or could be non-pharmacological. And in the pharmacological treatment, you have anti-allergic drugs, anti-inflammatory drugs, lubricants, and systemic therapy. So anti-allergic drugs, as the name suggests, are most effective, which could be topical histamines, antihistamines, mast cell stabilizers, and dual-acting drugs. And topical antihistamines are generally histamine receptor antagonistic, which are given in QID doses, such as levocabastin and amidestin, and they cause transient burning sensation and dry sensation also. Mast cell stabilizers are used, such as sodium chromoglycate or nidochromal sodium, which inhibits the mast cell degranulation, again given in QID doses, and dual acting would have both. That means there would be antihistaminic as well as mast cell stabilizer, and so it's given in BD doses, and there is transient burning sensation. But examples are bepotestin, ketotifen and olopatadine. So initially when the patient comes, I generally like to give lubricants, because the lubricants, they wash off some of the allergens. The second drug in mild cases, which possibly I'll give, is topical antihistamines, and because they block the inflammatory effect of the endogenous histamine, and drugs which can be given are levocabastin or amidestin in QID doses. Now, they are not going to treat the disease, but they are in some way going to decrease your symptoms, but this burning sensation and dry sensation will definitely be there. So if it is a mild disease, then you can try topical antihistamines, but be careful, all antihistaminics will cause some element of dryness or dry eye. So preferably avoid them in severely dry eyes. And mast cell stabilizers could be your sodium chromoglycate, nidochromal sodium or lodoxamide, which inhibits the mast cell degranulation and prevents the release of cytokines. And lodoxamide also inhibits the eosinophil activation and degranulation, and nidochromal acts on multiple cells. Again, the frequency is QID, and it can be given on a long-term basis, although it is slow in its action. Prophylactic dosing can be given, and it is not enough to treat the disease. So once you know, especially when it is seasonal, that it is about to come, in those cases, just prior to the season, when your allergic eye disease gets activated in the patient, this can be given, but it will again cause transient burning sensation. I think the most popular ones, or the most which are used nowadays, are the dual acting ones, which are both, which would have a histamine receptor blockade and will have a mast cell stabilizing property. And also they have some amount of anti-inflammatory property, because it will inhibit the release of various mediators and chemotoxins, etc., which will also decrease the vascular permeability. Now, the commonly available drugs are epinastin, ketotifen, olopatadine, alcaftadine and izilastin, and the frequency is again twice a day. Now, they act very rapidly because they have an antihistaminic, and they will also give you long-term benefit because of the mast cell stabilization, and would have minimal adverse events. Then amongst the category of anti-inflammatory, you have topical NSAIDs, corticosteroids and immunomodulators. Topical NSAIDs I generally don't like to give, because these patients would often also have some ocular surface disease, and then if you give topical NSAIDs, then this gets aggravated, and these could be ketorolac or diclofenac. The frequency is generally 2 to 3 times a day, and like I said, most cases would like to avoid these drugs. Topical steroids you may have to give in the form of lotoprednol, FML, dexamethasone, betamethasone, prednisolone or difluprednate. So if it is a mild one, I would rather give a lotoprednal or a fluorometholone, because that is more surface friendly. If I have to use dexamethasone, betamethasone, prednisolone, I would do it for more severe cases. But for milder, moderate cases, one can use fluorometholone or lotoprednol. And generally it is preferable to use steroids with a low strength and low effect on intraocular pressure, especially when they are steroid responders with increase in the intraocular pressure, which include fluorometholone, even remoxilin. I don't know if this is available here, or even lotoprednol. The latter two are definitely available here. So as far as the steroids are concerned, there are two treatment regimes: the pulse to the prolonged treatment. In the pulse treatment, you give it TDS or QID for 3 to 5 days. In prolonged therapy, you give it 3 to 4 drops per day for 1 to 3 weeks, and then do a slow taper, especially in the chronic forms. And in very severe cases, especially in children, when you really have to break that cycle, that vicious cycle which is there, then in those cases you can also give a short course of systemic steroids, because that will break the vicious cycle. Supratarsal injections of steroids in regular or depot formulation, I'm sure Somshila must have talked about. And of course, one has to be careful because there can be raise in intraocular pressure, glaucoma and cataracts in these cases. Immunomodulators play an important role as such also in allergic eye disease, and also when the requirement of the topical steroids they increase. So you can use either cyclosporin or tacrolimus, and cyclosporin is available in the concentration of 0.05%, 0.1%, even 0.9%. And there are various forms of it which are available, which include the nanomicellar one, and there are various other variants also which are there. And tacrolimus is available in the ointment formulation, varying in concentration from 0.03 to 0.1%. People where rare, very refractory cases have also used topical mitomycin. Now, topical vasoconstrictors can be given, but again, their action does not last for too long, and they may cause itching and redness, and more importantly, dryness. I think topical lubricant should always be given in allergic eye disease, whatever drug you are giving, whether you are giving dual-acting one or antihistaminic, or the one which is mast cell, causes mast cell degranulation. And like I said earlier, people have tried systemic steroids. Oral cyclosporin has also been tried. IV immunoglobulins have been. Then there are other biosimilars which have been tried for the same. Of course, the non-pharmacological treatment will give some amount of symptomatic relief in the form of cold compresses, saline and cold artificial tears or ointments. And one should avoid eye rubbing, and if it is very severe, then one can wear dark goggles. So, to conclude, in mild cases, like I said, in all cases, mild, moderate or severe, I would like to give lubricants. If it is a mild one, then only antihistamines. In moderate cases, dual acting one. In very severe cases, you may use immunomodulator, sometimes even topical steroids. And once you have to break the cycle, then systemic steroids can be used, especially in cases of children. Also, important thing is that prophylactically, when you know that it is seasonal and it is going to come year after year, then prophylactically the dual acting drugs can be given when the season starts. So thank you very much for your kind attention.
Ma'am, what's your experience of using 0.5% cyclosporin? Is it really effective in allergy, or what's your take on that? Because normally we have read it's 1% or 2%.
So for allergic eye disease, like for other indications, you could increase your concentrations of cyclosporin. I feel for allergic eye disease, 0.05% is good enough. You really don't need to increase the concentration of cyclosporin. If I had a choice, if it was still not responding, I would increase the dose of steroids rather than the dose of cyclosporin. Any other question, any query, anybody wants to talk about this? Both are similar. I somehow prefer, because I tend to give more fluoromethalon. So my go-to drug is fluoromethalon. I have no financial interest in any of the two. I don't think so. Both perhaps act similarly only. But like I said, if it is an inflammation which is inside the eye, and I'm sure Somshila can pitch in for this, you could go in for, steroids like dexamethasone and betamethasone. But if it is on the surface-friendly topical steroids are fluoromethalon and loteprednol. Anybody would have experience between these two, fluoromethalon and lotepred?
No, I strongly believe that you can use either of the two drugs. There's some preparations, if you want to be very scientific, there's some preparations of fluoromethalone which have more propensity to raise the intraocular pressure. And loteprednol has a couple of 2-3 doses, strengths formulation which it's available. So those are the only reasons. So fluoromethalone is more of a solution and loteprednol is more of a suspension. So these are the reasons. I honestly not sure if it makes any difference between the two. You can select whichever you're familiar with.
So GPC, cyclosporin eye drops in general you can give for years together. It is not going to have any harmful effect except that it may cause stinging, which happens in 17% of the cases. But otherwise it is not secreted in your blood, or it doesn't cause any systemic effects for sure, and will not cause effects even locally. People have given it from ranging from 1 year to even 5 years. We have studies with 2 years. So 5-year follow-up is also there, and that too in children is also there.
And then my long-term savior is tacrolimus, so that I bring it a little later and keep that on. So as you were saying, more of verbal therapy works the best for this group of patients. As many years as they get fed up with you.
But
So,
tacrolimus
yeah.
tolerance is much
So-
less as compared to cyclosporin.
Correct. So that's the reason to switch it to the lid skin, and also it's not free of complications. So we should give a drug holiday from tacrolimus. There are some studies which show that it can have some issue related to malignancy, but luckily in ophthalm literature or in whatever expert opinions you have, there is no such association. The stinging is a commonest complaint, and it's known to cause some pigmentary changes because it's something using on the skin surface, so it can cause some hypopigmentation if you keep on using it forever and ever. So when the child has a non-allergy period, the cool months, and the parents tell us that that's the pattern, so you can ask them to, okay, stop tacrolimus, and even before spring comes, let us say that Feb, March they start getting active, so from January tell them start tacrolimus, something like that.
So tacrolimus typically also, if you inform the patient beforehand that they are going to have these problems of stinging and burning for the first 3 days, then typically they are more open to using it for a long term, because those symptoms actually wane down. In the next 4-5 days, the patients become more comfortable and more tolerable to tacrolimus. Tacrolimus. I use tacrolimus same as ma'am because I have done my fellowship from LP Prasad. So tacrolimus works very well and we can be continued for a very, very prolonged period of time, like ma'am rightly said. To my mind, how I use lubricants in ocular allergy is that I tell the patient, if you feel like itching, instead of itching, use this drop. So I give them a lubricant as SOS. Rest of the therapy continues because they have a tendency to itch. It's very important to understand the psyche of these patients as well, because they are into that chronic cycle of itching which makes the allergy worse, and then they keep on suffering. So I tell them, if you can't do cold compresses, because a lot of them find it very cumbersome to do cold compresses every time they have itching, you keep this drop with you wherever you are going. Put one drop when you feel like itching. Try to avoid itching as much as possible. That's how I use it. Yes, rubbing.
For mild conditions, just to add that sodium chromoglycate or olopatadine or dual agents, they do work very well. So for mild allergies, yes, we should use them as well. Sure. Yes, sir.
As Madam has already mentioned about the malignancy, it's very, very important in the present scenario of medico-legal aspect. So when you give either cyclosporin or tacrolimus or any drug of this kind in the children at least before the age of 12 years, you are highly vulnerable if anything happens. So I never prescribe these drugs to the younger children because there is no trial has been carried out with this low dose whether it can produce or not. But in the higher doses and the systemic conditions it has been documented. So this is one. And VKC steroids are recommended, but it's a double-edged weapon because if some patient is a steroid responder, since I work with the both glaucoma and cornea, I know that how many cases of VKC has come with the silent glaucoma. No congestion, nothing, no symptoms and pressure 40, 50 or so. So that is very, very word of caution that whether you use FML or use any steroids in any patients, whether you use children or elderly also for the allergy, the periodic pressure should be checked. Within a week time, I have seen the pressure has shot up. So this is one. Cyclosporin in elderly patients, particularly those who are diabetics or glaucoma patients, it has been documented by OCT and the literature is available that it may lead to the RP changes and the ganglion cells are affected. So in the elderly patients with these compromised bodies, when you are going for the cyclosporin, you should see this OCT should be done and then we can go ahead with that. Thank you very much.
Yes, yeah. There was a question in a young lady, yeah, and then sir in the back. Yeah. Thank you for your points.
How do you decide that now is the time to start tackling this?
Would you like me to answer or? So, as Alok was saying, that there's a step ladder approach. So for the mild cases where there are mostly symptoms but not too many findings, then you can use lubricants and keep some companies happy, whichever you're using. And of course, olopatadine or mast cell stabilizer is one of those. So that's all that's required. Remove, if you can find the allergen, then modify all of that. Then you go to the moderate cases and then the severe cases. So tacrolimus is more for the moderate cases, severe cases. Wherever you feel that this, by history, you know that the patient has recurrent disease. Usually it's recurrent, comes in every year, sometimes it's perennial. So you need something for maintenance. And as sir pointed out, you can't use steroids. And sometimes just using olopatadine or sodium tacrolimus is not adequate. So those are the cases where tacrolimus is going to be the long-term maintenance. Earlier days it was cyclosporin. I used to use that as well. So this is only our LVPI protocol that now we believe less and less in cyclosporin. We switched to tacrolimus. But if some of us here may have had good experience with cyclosporin, so there's no problem, you can use that drug as well. So these are the two choices. There is sir, okay, sure. After you, sir, in the back. Yeah.
What are your views on oral steroids in severe cases as compared to the immunomodulators in severe cases?
Yeah. The question is, how about oral steroids?
As compared to the immunomodulators for the severe cases.
Right. For the severe cases, so oral, any steroid to me, whether it is oral or topical, it is a bridge therapy. I am not using this as my final control. My final control is a safer drug, if I have one. So say tacrolimus and so on. So oral steroids is to jumpstart, to like sort of crush the allergy, like give a pulse in patients where they're so severely affected that they're not attending school or they have all of these changes that we mentioned in our presentations. So then I start off the patient oral steroids. You don't need to be aggressive. It is not like uveitis or like scleritis. So you don't need to go with 1 milligram per kg. You can go at an anti-inflammatory level. For a pediatric patient, maybe half milligram per kg or quarter milligram per kg, and use that for a few weeks, stretch it to not more than a month, I guess. By the time you'll have control of the disease, and you review the patient frequently. And
what I was to ask was, will you be also following it up with immunomodulators?
Yes, only in the severe cases. So I would say that if you're practicing on your own as a general ophthalmologist, these kind of cases should be referred to tertiary care. So the severe cases, because you need, it's a pediatric patient most of the time. You need a rheumatologist, you need a pediatrician along with you to manage, because you're giving drugs which are not first level medical therapy. So you need in collaboration with these people. So yes, we would use immunomodulators, and these are luckily, they're very reserved for a small subset of patients. But yes, that is also there. In the step ladder, it's the topmost in the step ladder.
One point of concern here is, what has been observed,
Yeah.
People keep lingering on the management with the topical, and the child doesn't get effective management. So it's better always to start oral and for a short duration and then switch over. That's also.
Yeah. So sir had been trying to ask questions for a long time. Yes, sir.
Yes.
Comment or question? Yeah, we are going to hand over after that.
Out of chloromethanol and norepinephrine, what I feel is norepinephrine is better tolerated as compared to chloromethanol, but theoretically more risk of penetration and complications with norepinephrine. So which one you prefer?
Maybe you can take it.
So, depends, whatever works well in your hand is a simple answer. I typically use chloromethalon more commonly than loteprednol. I tend to work well in my hands. Like Dr. Somshila was rightly saying that loteprednol would have lower concentrations are available for formulations which would probably have lesser chances of steroid-induced glaucoma or steroid responders, so to speak. Fluoromethalon, I would more closely monitor the intraocular pressure. So I typically do call them again after a week once I've started them on fluoromethalon, all the patients, and dilate and see the optic disc just to rule out any signs of glaucomatous changes. Fluoromethanol, I feel, is slightly more potent as a surface steroid than loteprednol, especially when we are using low strength of loteprednol. So it depends on the severity that we are treating. We can even in some cases we might even step up to prednisolone acetate. So there is no hard and fast rule of what steroid needs to be used for ocular allergy, or typically VKC is what we are talking about here. So it depends on the severity and depends on what works well for you and how frequently you can monitor the patient.
Second, second part.
Right.
Out of
I think we can take the discussion outside. Thank you so much for being here on such an early in the morning and being actively interacting with us. We've had a wonderful course, and I thank all my speakers